Hello, everyone. Today's topic is a pretty broad topic. I would not say it is streamlined to CCS cases or something. It's very general, ED specific case that is a young female around 28 years old brought in with unconsciousness. Okay. And let's say she threw in a seizure even when there was no seizure noticed in the past. So the recruiters or the ones who saved her during the transition to the hospital um, gave her a shot of diazepam. Diazepam. Um, so let's say she's female. And so, what are your steps? How will you manage this patient if she arrives in the emergency department? Okay, it is a very interesting case. Um, Initially, we have to hurry up, right? So she has a overdose of something. There could have been a head injury, or there could have been concomitant alcohol overdose, um, with which she was brought in. She's unconscious. So immediately you need to place her on airway ABC measures, okay? Secure the airway, breathing, and circulation. Once you do these three, you're almost on the right track. So for the airway, you have to intubate this patient. So before you are sure if you want to intubate or retreat aggressively, start with simple orders. Go with pulse oximetry. Okay. Whenever the pulse oximetry is way too low, around 88 or 75, you may always want to go ahead and give the patient the oxygen. Intubate this patient because she's unconscious. Her Glasgow coma scale was at the same time very low, around 3. So when you intubate, make sure you are also including NG tube in there into the orders because we don't want aspiration. Okay, so this way we are securing the her airways, breathings, and for circulation, do normal saline. Okay. Once you do this, then you can go ahead and hit the physical examination. Okay. We do not want to go ahead with physical exam in this typical scenario. We first want to stabilize the patient. So when we are doing the physical exam later on, we will see how the patient is doing. Now let's narrow down and steer up the exact investigations of choices in order to get to the treatment. So the first order is salicylates. Okay. For any patient walking in with the subconsciousness, we want to see certain overdose drugs that are potential factors. So one is salicylates, other one is acetaminophen, normogram toxicity. Acetaminophen. Then go with TCAs. Tricyclic antidepressants being one of the most common causes of overdosage. And finally, the most important, ethanol serum concentration. Along with the serum toxicities, we also will check, we also will have to check urine analysis to see if there is any toxic components in the urine. Okay. And think about general causes of patients presenting with altered mental status. Please do not forget to do the glucose levels because hypoglycemic episodes are one of the most common causes for subconscious patients. And then once the patient is stable, we also might want to look out for a head trauma. And so go ahead and do the CT scan of the head. In any case of falls or those with altered mental status, we can do CT scan. Because here in uptended patients, there is always a chance of injury, and so this can potentiate our toxic components, leading to altered mental status. Now, in terms of treatment, what we can do is this is all loaded. Let me get it down here. Yeah. Okay. Let's get to the treatment part. Firstly, if depending on what kind of overdosage, uh, in general, I would like you to remember some key points. For any overdose patients, you may want to start naloxone. Okay. Why naloxone? It's because sometimes the naloxone can improve the situation. It could be morphine overdose. So simply whether we suspect morphine overdose or no, we can start the patient on naloxone. Um, if the patient doesn't improve, then it's definitely something to go a little more broader and think about other causes. Okay. We can also start the patient on activated charcoal. Typically, it is said to start activated charcoal within 2 hours of presentation. However, regardless of whether the patient presented to you after 2 hours or maybe um, uh, after 4 hours or even after unknown duration, we still go ahead and uh, give activated charcoal. It is considered to be safe enough. And then when you do the EKG, there are typical findings that you would see if a patient has TCA overdose. So in the most likely it can be ethanol or TCA overdose. So in the EKG, you can see like a prolonged QRS, widened QRS, prolonged PT, QT intervals. And also when you do the ABG, there will be acidic pH, no? So in that case, you can go ahead and give soda bicarb. Apart from that, the moment you see EKG changes, you need to start the patient on soda bicarb. Sometimes the sodium channels could get blocked and it may not work. In that case, you can give lidocaine. Typically, in a patient who has tricyclic overdosage, we remember it as 3 Cs. The 3 Cs here include coma, convulsions, and cardiotoxicity. So in convulsions, if a patient, let's say when brought in, has thrown up a seizure, you can always give diazepam to seize the patient from having another seizure episode. All right. Why do you think the patient threw into a seizure? Because there is a very interesting mechanism behind the TCA overdose. Let me break it down to you. In the TCAs, there is anticholinergic properties. Again, C stands for cholic. So cholinergic properties means there will be anticholinergic means like dry eyes, dry mouth, tachycardia, as well as seizures. It basically messes up with all the electrolytes, causing cardiac arrhythmias. So, this is something to be watchful about. Always look out for patients. They can end up having arrhythmias. And this is like a very common potential complication for seizures. Whenever a patient has hypotension, you may also want to do um, epinephrine, norepinephrine in addition to normal saline. Okay, because there is adrenergic component as well. So with this, I wrap up today's video session, and I hope it has been clear to you on how to manage a patient with subconsciousness, or let's say completely loss of consciousness. There can be a lot of other situations. Um, Maybe the patient was brought in due to, let's say, some other cause, or maybe morphine overdosage. So, in any case, we have to refer these patients to social services, rehabilitation, and have them checked with a psychiatrist so that they do not have another risk for overdose or suicide attempt. Okay, so this is a really great case, and so it's something to kind of remember as soon as you can see the patient. So probably you can also look out for pupillary dilation or other mechanisms. So um, in a typical situation, if a patient is brought in um, with unconsciousness, we usually go ahead and do the EKGs. In the EKG, again, if we see QT interval prolongation, widened QRS, and so on, make sure to give sodium bicarbonate. Okay, thank you so much for watching my video. I will see you in the next one.